Welcome to Joint Effort with Des Moines Orthopedic Surgeons. This podcast covers the pain and injuries that are associated with muscles, ligaments, and joints.
Welcome to another episode of Joint Effort. I'm your host, Jason Sullivan, here with Dr. Matt DeWall. Welcome aboard.
Thanks, Jason.
Thanks
Good
for
to be here.
Yeah, thanks for coming on. We appreciate it. All right, our task today is to talk about revision total joint replacement. A really boring, long name. We're going to get there, but I want everyone to get to know you a little bit first.
Sounds good.
We were kind of talking before this, and I was, you have a wife and two kids?
Yes.
And I was actually watching this documentary about sustainable living, sustainable food, how you can do this on your own. And I got to thinking that I know Jen has a nutritionist background.
Correct.
And I got word that she's, you grow some vegetables in your basement maybe. She's very nutrition-centric focused, which is funny because, knowing you and we talk all the time, it just doesn't, you know what I mean? It's not your thing, but it's clearly her passion.
Right.
So
right.
Tell me about this. Are you eating from produce in the basement, or how does this work?
Basement produce sounds bad, but she's got it's called a tower garden, and it's a hydroponic water system with grow lights, which sounds shady in other ways maybe, but she grows a lot of lettuce and herbs and kale and spinach and all sorts of stuff down there. And you're just growing that? Correct.
Nothing suspicious?
No.
Okay, fair enough.
Although I wonder when the UPS guy delivers these things if it's
he's
starting to wonder.
What are we getting?
Yeah.
So, and you've had this on your plate for dinner or lunch, and
yeah.
Does it taste like it's just from the store? Or?
Yeah.
No kidding. You don't notice a difference?
Probably better. It's fresh. It doesn't go bad in your fridge right away, and it's good stuff.
So we don't need to have something outside to grow healthy, nutritionist, meal. Huh. Interesting. Okay. Well, another thing, so you have two kids and you live on a huge pond.
Correct.
And all you ever show me around the OR is these massive fish that your kids catch.
Yeah.
The funny thing that struck me was, I think it was your 4-year-old was showing pictures of this, and my kids are like 9, 11. I haven't even taught them to fish yet. So, you're a pretty outdoors family. You guys like to get outside, and you're teaching these kids all sorts of skills.
Take them fishing and hunting, and again, that kind of rolls into that sustainable food thing at times.
So when you take them hunting, if you get a deer, are you guys eating the entire deer?
Yep.
Okay.
Yep.
And you're only shooting at big bucks. Is that how it goes around Iowa?
No. Kids don't get that picky.
Can they take a doe?
Yeah.
Oh, they can?
Yep. Both my kids have got a doe this year already. So.
With the bow?
No, with the gun.
Okay. I thought it was only bow season.
No.
Okay.
They have a kids gun season early on.
Okay. But you're picky.
Kind of.
Fairly
yeah.
picky.
Yeah. I don't need any more deer meat right now. So.
Okay. So when you're in the blind and you see nothing for 6 straight hours, are you thinking about revision total joints?
No.
That's the last thing you want to think about?
Correct.
Okay. Well, let's get into some of the reasons why, and they can be super difficult. Before we get there, how did you get to ortho in the first place? You're from Iowa, Pocahontas.
Yep. Grew up in northwest Iowa.
Population of?
About 2,000. I grew up on a farm outside there.
And we have 2 orthopedists in our group from Pocahontas.
Yes.
Chances of that are super slim.
Well, when it's a great town like Pocahontas.
We have a nurse as well, and then
Yep.
all sorts of good people from Pokey.
Yep.
That's a good Pokey plug. I don't think I've met a dishonest person from Pocahontas yet, so you're doing something right there. So then where'd you go to undergrad?
I did undergrad at Iowa, and
Okay.
I did med school at Iowa, and
Okay.
I did my residency at Iowa.
All right, so that's like every other podcast I've done where everyone just is like Iowa. But as mundane as that is, that's kind of an elite education right there.
It is. It is.
Especially in the orthopedic world, professionally, world-renowned
Right.
Group up there. So then from there, you went to Australia.
Yeah.
For a year?
Yep. So I was there for just over a year with my wife. It was before kids, but I wanted to do a fellowship, and having been Iowa,
Mm-hmm.
the opportunity to go somewhere different was appealing, and got set up through one of my mentors at Iowa to do a year in knee surgery in Sydney, Australia.
Was that a tough sell for Jen, or was that?
No, she was on board.
She was?
Yeah.
Okay. And after you did it, was it just the best year of your life?
Yeah, it was good. It was, life-wise, culture-wise, training-wise, everything was good.
Okay. And so going to Australia, is everything the same as in the U.S., or is it?
No, not necessarily. I mean, it's funny, as you would know, you go through residency and then you go to fellowship and you find just in general there's even if you did it here in the U.S., there's different ways to do things. You sort of come out of residency sometimes thinking that's the only way. But then the healthcare system in Australia is different than ours, and so, there was a lot of new stuff to be learned.
Yeah. Do they have a socialized system there?
They have a combo, so they have a private and a public healthcare system. So
really?
Yeah.
Does it seem to work okay?
Yeah, I mean, just like anything, I don't know there's any one right answer there.
Right. Okay. So, yeah, I think one of the most interesting things about orthopedics in general is that you take the two guys who are really well trained, West Coast, East Coast, wherever, and they might do the same procedure and get there a totally different way.
Yeah.
So I can imagine that you brought some of those experiences from Australia back to Des Moines, and you probably still implement some of those things.
Absolutely.
So your practice, I'm fairly familiar with it, is primarily adult reconstruction, which means total hip and total knee replacement, and you also do everything in the knee, which includes ligamentous reconstructions, meniscus work, and things like that.
Yep.
In addition, we all take call, and so you do a fair amount of trauma.
Correct.
I actually remember you don't remember this. I was a fourth year rotating at Iowa. You were the senior on trauma, so you looked kind of bleary at the time. But someone made the comment, they're like, that guy right there, that of your senior class, you were like taking trauma in the summer. They're like, that guy's a stud.
Yeah, that was always that was kind of the badge of honor. If you picked to do 11 weeks of trauma during the summer at the University of Iowa your senior year, that was nobody wanted to do it, but if you got first choice, you had to pick it because it was.
If you shied away from it, you were labeled.
Yep.
So did you pick it then?
I actually got second choice, and the guy ahead of me didn't pick it.
Oh, so shamed forever.
Yep.
Okay.
And so I took it.
Well, I just remember that, and I'm like, okay. And then you joined this practice, and so did I. So I'm like, your reputation preceded you, even though I didn't work with you. Anyway, so let's talk about this. So the word revision in general, everyone knows the definition of revision, but when we're talking about knee and hip replacement, we want them to last forever.
Right.
But we know they probably don't.
Right.
What are the reasons that a total joint wears out?
Well, it can be just that. It can wear out. There are parts of the joint, whether it's a hip or a knee, that can wear. Usually it's the plastic parts that are there. But there are other reasons it can need redone or revised. It can be instability. It could be loosening of the implants from bone. It could be something like infection. So there's a number of reasons why a joint would need revised.
So in general, most knees and hips both have that poly insert, right?
Yeah, most.
Between the metal components.
Correct.
And that for a long time was considered maybe one of the weak links in the system.
Yeah.
Is that fair to say?
Yeah, I think so.
And those materials have gotten better over time.
Yeah, I mean the makeup of the materials, how they're sterilized and how they're stored, and all those things have improved significantly.
The problem is maybe seems like the poly science in the last 10 to 15 years got a lot better with cross-linked and things like that.
Yeah.
But the revision you're seeing that are loose and having problems, my guess are things that wore out maybe 15, 20, 25 years ago.
Yeah. I mean, we see a lot of joints done 15, 20 years ago. Some still working well, but some obviously needing redone.
So when someone comes to you in the office and they had a joint replacement 20 years ago, let's say they had a knee replacement, what are the typical complaints so people understand along the way when they have a joint kind of what to look for? There's some normal aches and pains with the joint replacement that can be just kind of what it is.
Sure.
And then there's some things that can be alarming or you need to seek attention. What would you tell people?
I think the biggest thing is just a significant change in how that joint's been functioning. So, you had a knee replacement. Most people, although it may not be perfect, would say it's much better than the old one was, the arthritic joint. And that continues to function for, X number of years. I think the concerning finding would be something that is significantly different or worse. It's hurting more, it's swelling more, it's feeling more unstable or giving out more. Those kind of things would be a big red flag change.
Okay. And if you see someone who's telling you those things in the office, how does your workup go? Obviously, you talk to them about those things you just mentioned.
Right.
And then what else do you do to kind of figure out how we attack this?
Just like anything else, you start with the history, like you said, in the exam, and see what their joint looks like, feels like.
Can you tell in an exam if things are a problem?
Sometimes yes. I mean, you can, and especially if it's a patient you've been caring for a while and you can yourself remember or notice a change. But then it goes to, x-rays, and sometimes other studies like a CT scan or a bone scan would be used as well.
Okay. So if you get x-rays, what do you look for in x-rays where you kind of say, okay, this joint's going downhill?
Well, you can see, a decrease.
For instance, a knee. Let's go.
So for a knee, you'd be looking at, that space on the x-ray that's representing the poly that's there, if it's narrowing down, if it's wearing thin. And then you can see other signs between the metal implants and the bone, whether they seem to be loosening, whether they're changing in position.
Okay. And if for a lot of people, in regards to the knee, traditionally knees are cemented in the metal,
most often,
the metal
yes.
parts.
Yep.
So you can sometimes see maybe a little cement mantle, and then the implant, and then the bone, right? So there's a couple different interfaces you can look at and see.
Correct.
If you see that, you just see on one side of the joint the spacer, which you can't see on x-ray, but the space is narrowing, and someone's not that symptomatic, can you watch it, or do you have to do revision surgery?
No, there's plenty of times where if you don't see, their symptoms are mild or not having symptoms, and you see some degree of that wear, it's certainly something you can watch, and that just depends on, what the surgeon or you feel is right and the patient wants to do, but maybe just telling them to monitor their symptoms and take another x-ray in a year or 6 months or 2 years or whatever you think is necessary.
And on the flip side, what if you see that the metal components or the cement mantle is loosening and you're seeing some kind of shadows there? Is that a more pressing situation where you kind of recommend, okay, we need to?
I think so. I think often then the patients are having more symptoms, but certainly if your
symptoms would be mostly
pain, swelling, yeah.
Okay.
But certainly in that case, you don't sometimes want to let it go too far. There are some cases where you can continue to watch that if their symptoms are mild, but you worry about bone loss or bone destruction to where it makes the eventual revision more difficult and possibly the end result not as good.
Okay. Hips and knees are a little bit different in their mechanism. When you say wear, we say it so frequently in ortho, but help a person understand, what is bad about, this wear? Like, what is the poly kind of like flakes off, and describe kind of what it does.
So the big problem we think is that, the plastic, the poly wears, and it wears in very small particles, which are irritating to your body. So your body tends to, certain cells eat those up and get rid of them. And we think that in doing so, then that can, eat up some of the normal tissues as well, which then causes problems.
Okay. So ultimately, you want to preserve as much native bone as they have, as you can have for your revision.
Correct.
And that gets into my next question. What is so difficult about revisions? Everyone thinks, it should be just like doing a regular knee or hip replacement. What are the factors you're thinking about ahead of time that you just can't account for?
Well, there can be any number of things you run into. Whereas, primary arthroplasty may be, although there's possibilities of unusual things happening, it can be much more sort of standard or run-of-the-mill. Every revision's probably different. And it just depends on how much of that normal tissue is still there, is still useful, both bones as well as, ligaments and other, structures around the joint can become compromised. So you've just got to have more options, more planning, and often take things a little more carefully.
And your OR time, I would guess, can be completely variable.
Yeah, there's simple, easy revisions, and there's ones that are, several times longer than a standard knee or hip.
Right. Let's talk about, so the knee that's loose, and sometimes those components almost fall right out. They're easy to take out. Let's talk about another reason for revision in a hip. Let's say like a hip dislocation, and they've been put back in place a couple times and they keep dislocating. And so let's say it was something done a long time ago and their soft tissues have gone downhill and they keep dislocating. That revision can be kind of simple in some contexts if you just have to change the cup. But what if you have to take the stem out in the hip? Is that can be that you can get into kind of quite a hassle to getting that out, correct?
Yeah, if you have to take out well-fixed implants that are not loose, you just like you worry about your body or the reaction to wear destroying bone, you have to be careful not to do it yourself. Sometimes for a hip, for example, you actually have to cut part of the bone away to get the implants out and then repair that when you're done. And again, that can prolong both surgery time and possible complications, but also recovery time.
In general, what's harder to get out, a cemented stem or a press fit stem in your experience?
Just depends.
Does it really?
Yeah.
Okay. But most primary total hips are going to more of a press fit technique, is that right?
Non-cemented bone ingrowth. Yeah.
You think there'll be a day where we're seeing like very few cemented, or are we already there where you just see very few cemented?
I think the vast majority are uncemented today, though I still do for, older patients with poor bone.
Okay. Another type of revision that no one wants to talk about, but it's infection. And so it's one of the things you counsel people about ahead of time when you do a total hip and knee. And I've been a part and seen how difficult those conversations can be. So selecting the right patient so that you don't do them any harm and minimize their complications is a big deal.
It is, and I think it's become more and more of a big deal over the last few years. I think as orthopedic surgeons we know more about that today than we did when I started 10, 12 years ago.
So give me some parameters that you look at that you say, hey, we really should optimize these before we do a replacement.
I mean, the ones that you can control, one would be weight. I think that's the probably biggest one and sometimes the hardest conversation to have, but there's some better studies lately about obesity and BMI just as a risk factor in general for complications. Diabetic control, if people are poorly controlled and their hemoglobin A1C is off the charts, I mean, that's something that can be modified and make the risk of infection lower at the time of surgery. I think smoking is another one.
How do you handle smoking? I think everyone's a little bit different, right? It's really hard to tell a long-time smoker they can't smoke.
It is.
But sometimes it's almost necessary to have that conversation.
I think it's handled differently by every surgeon, and personally it's not a in and of itself deal breaker for me, but if they're a smoker and heavy and diabetic, you start to add up these things, then you've got to see which ones you can work on.
Okay. So let's say someone comes to you and you're concerned for an infection. We kind of just differentiate between something that happened very recent and something that's kind of happened over time maybe. How are those handled differently in your mind?
Well, with an acute infection of a prosthetic joint, there is some degree of treatment where you can not have to remove the entire joint and treat it just with irrigation, debridement, and perhaps changing some of the modular parts of the joint and either suppress or cure the infection. The chances of you being able to treat that, acceptably if it's a more chronic infection go down.
Okay. And why is that?
The bacteria get a better hold. Sometimes they even infect the bone. You get what's called osteomyelitis. They get more of what's called a biofilm on the implants themselves, which can be difficult in all those kind of small places of the joint to eradicate well.
The biofilm thing kind of baffles me. When you're looking straight at it with the knee, you think, why can't I just scrub this and get rid of it? But it's like its own organism in and of itself, right? It's kind of set up. It's not going anywhere. So if you've just recently done a knee and somehow you think they're infected, that's probably the best chance where you can get in there, wash things out, retain your initial components.
Correct.
And that's a big deal because if you can't retain the components, walk people through kind of how you get from an infected total knee to a good revision total knee that's not infected. How does that go?
It's a big process. So if you don't think you can treat it with a one-stage treatment like we've talked about, and you have to do what's called a two-stage treatment, then it involves taking out those implants, which often are not loose, so then you run into all those issues we just mentioned about preserving bone and things to work with later. You've got to get rid of those implants and get rid of the place we think those bacteria are living. Often we put in a temporary sort of implant, but made of some cement with antibiotics so it can deliver antibiotics locally.
And they can kind of function then?
Yeah, I mean, it kind of holds the place of the joint, but we often don't let them walk on it, and they often, if it's a knee, need a brace and things like that, and then treat them with intravenous antibiotics often as well with the help of the infectious disease doctors.
So they'll have an indwelling PICC line sometimes?
Yeah, usually for a couple months. And if we follow them along and it appears the infection is cured and going away, then usually, 8 to 10 weeks down the road, you can hopefully come back and then put in that new revision joint.
And do you usually wait for the infectious disease doctor's blessing, and then you kind of look at the soft tissues and then?
Yeah, there's a lot of checking. It's both the guidance of the infectious disease doctors as well as looking at blood work we can do, and then even sometimes using the pathologists at the time of surgery to look at the tissue again.
overall, any revision, all comers, is the success of a revision as successful as a primary total joint?
I would say probably not. Certainly that's what we're shooting for. We're shooting for it to be
So
just
that
as good.
It can happen.
It can. But I think just in general, with the patient's often that much older, I think the tissues are often that much, less quality, and the implants and types of things we use sometimes aren't quite as high functioning. So.
Okay. And as we get to a population that is so much younger, we're seeing so much worse osteoarthritis in late 30s, 40s. So a lot of times they don't have much of an option. Joint preservation, you do that in your own practice, and if you deem that that's not going to be successful, and you think they've tried all these conservative things and they're miserable, and you're doing a knee or a hip at a younger age, is it more important for them to pay attention to the certain restrictions you put on that joint so that they're not sitting in a situation they need a revision?
Yeah, I think there's a kind of double-edged sword there. The active young patients want to be active, which is why they do it. So certainly you don't want to tell them not to do anything. But I think kind of common sense stuff, often lower impact exercise, trying not to do things that put them at higher risk of tearing something up, having a fracture or other injury, and then also trying to keep themselves healthy and keep their weight down and things like that.
Okay. In general, what % of your practice do you think is revisions?
Probably 5 to 10.
And do you think it's going up?
Yeah, I think so.
You do? Will it reach a point where the primaries are so good and the implants are so good that it stabilizes or goes back down again? Or do you think just with the population as it is and the amount of joints we're doing, it'll keep going up?
I think maybe percentage-wise it'll kind of equalize, but if you look at the number of joints projected to grow, total joint arthroplasty in the next 10 to 20 years is, going to grow hugely. I think there's going to be, even if it stays percentage-wise even, it's going to be a significant increase in the numbers of revisions needing done.
And I guess last question is that, everyone finds some of these unexpected things in clinic to be out of the routine, maybe even a hassle to some extent, but does this keep you intrigued as to, you're solving problems differently almost every time with a revision? You kind of have to have a bunch of different tools in your bag to figure this out. Like in some respects, once you get to the OR, I'm guessing it's a fairly rewarding case.
They can be kind of pull your hair out and sweat a little bit cases, but for the most part, yeah, it's fun and interesting to do some of this too.
Okay. Well, we appreciate your time.
Thanks for having me.
I don't think people realize, in terms of our group, which is a really large group, you handle a lot of these complex problems, and it just kind of goes towards your character and your skill set. And so if you can handle a hard revision, you can handle a primary. That's what the old adage is, I think. And
I hope so.
I think that's fairly evident here from talking to you today. Thank you so much for your time. We appreciate you coming on.
Thanks for having me.
Take care. Thanks for listening to Joint Effort, a podcast from Des Moines Orthopedic Surgeons. If you have questions about this podcast and wish to schedule an appointment with the surgeon, call 515-224-1414 or visit dmos.com.